Well, it's a real pleasure to be here and talk a little bit about failure of reverse total star arthroplasty and whether you should do a one-stage or two-stage revision. These are my disclosures. So the topic at hand is we're going to do a one-stage or two-stage revision for a failed reverse. The good news is failure rates for the reverses seem to be declining. If you look at this review article, in early failure rates were around 13 or even higher, and now in 2015 down to 6%. Also, Walsh and their group, even though it's a multi-center group, they found their complications, the revision rate, at least for reverses, went from 23% down to 9%, and their complication rate similarly decreased to down to 10%. In terms of whether you're going to do this operation or not, the learning curve for just even doing primaries is just 10 cases, and for maybe 40 for others is kind of hard to say exactly, but I think surgeon experience has definitely improved. I think most of us that do many of these have gotten better at it and aren't as many problems. The other thing that's real important, I think, is the survival of the implants. Fortunately, reverses have almost the same survival at 5 years, according to most systematic reviews, compared to total shoulder arthroplasty. So again, as it's been emphasized previously, it's really rewarding to help a lot of these patients that we couldn't help before. If you look at the longest term survival, though, reverse total star arthroplasty in terms of systematic reviews is almost the same as those reported for total shoulder arthroplasty. So fortunately at 10 or 15 years, they haven't started to fall apart completely, but at 15 years, the survival rate still is only 85%. So what are the most common causes of failure of reverse total star arthroplasty? Previously, back in 2007, it was just instability, which is quite a bit higher than it is now due to changes in the prostheses, but now it's down to only 4%. Infection hasn't really changed a significant amount. Base plate failure, which I think is the biggest thing to deal with, and as I mentioned earlier, scapular fractures, which can be quite debilitating, are around 1 or 2% at the most. So if you have a reverse that's unstable at follow-up, I think basically your options, particularly if the system's too loose, you just increase the inserts. If you have improper version or inclination, then you're going to have to revise either the humerus or the glenoid. And if you have an infection, you're probably going to have to remove the humerus and the glenoid. So if you have an infection, if it's an acute infection, then obviously just exchanging the components is going to be enough. If it's chronic, though, you have to decide if you're going to do a one- or two-stage revision, and our next speaker is going to address that, I think. But again, you have to take out the components, which is always a pain. So I'm going to deal with primarily base plate failure. John just dealt with how to deal with failures of not only anatomic replacements but also reverses. I'm not going to really deal too much with the humeral side. I think most of us know what's involved with revising or taking out stems or putting new ones in. But the major etiologies for base plate failure, number one, still remains infection. Aseptic loosening is around 1 to 2%. Osteolysis is a looming threat, but fortunately has not proven to be a big factor. And then obviously you can have a fracture of the glenoid, either due to occasionally these acromial stress fractures or scapular stress fractures go to the base of the implant, or the patient just falls. So if you have a base plate loosening in reverse, here are your options. Number one is to do nothing and just leave it. The other is convert it to a hemiarthroplasty. Third is convert it to a spacer, particularly in infections. You can do a one-stage revision or you can do a two-stage revision, and looming on the horizon is maybe custom glenoid components. So why would you ever leave one in place? There's lots of reasons. One is the patient has no pain. They're kind of satisfied with the current situation, and believe it or not, I have several patients like this who have just left it in. And oddly enough, it doesn't show so much in this x-ray, but as someone mentioned earlier, when they fail, the base plate tilts up and sometimes gets sort of trapped in the subacromial space, and oddly enough, they don't really care. There are also patients who, for medical reasons, you just don't want to take them back, and the patient doesn't want another surgery. And obviously, the other thing to consider whenever you're doing something like this, the revision risks are quite high, such as in a patient like this who has a fairly large BMI. So the other thing you can do is you can convert it to a hemiarthroplasty, as in this patient. It gives pretty good pain relief. They will get sometimes reasonable function, but not in this case. Of course, one of the reasons you put the reverse in is to prevent superior escape. And once you put in a Hemi, you're usually back where you started. Oftentimes, the glenoid is not reconstructible, and then patient factors like this woman who's a drinker, and we really decided not to go any further with her due to the complexity of any kind of revision. So the next thing you can do is convert the reverse to a spacer. We usually do this in situations where there's infections like this. You can put a spacer in as part of a one-stage, a two-stage procedure. Some people get good enough pain relief that they don't want to do anything else. So we sometimes leave the spacers in, and I'm sure all of you have someone who's living on just a spacer, and some of them can actually have reasonable function, again, depending on how much superior subluxation they have. So you can also put one in and leave it if the glenoid is not reconstructible. There are obviously patient factors like recurrent infection or liver failure or whatever. And some people actually will tolerate these as they function a little bit like a hemiarthroplasty. We looked at 50 spacers, and sometimes you're kind of forced, your hand's forced to do something. The complication rate when our 50 was 28% and 8% fractured. Oddly enough, 6% of them spun around the other direction, which looks kind of weird. Glenoid wear occurred in about 12% and required further surgery, and humeral wear, as you can see in the patient on the one on the right, sometimes it toggles and you can actually get sort of looming humeral stress fractures or real fractures. So the indications for revising a reverse to a reverse, primarily you need aseptic loosening. Obviously, I think with infection, and he's going to talk about it next, whether you one-stage or two-stage infection. The other would be instability. Humeral-sided failure is quite rare, but you need to have fairly good glenoid bone. Unfortunately, I think there was a comment earlier about how much bone loss you get with a total versus a reverse. And I think in either situation, depending on how loose the components are, you can have extensive bone loss with either type of prosthesis. But the bone loss with loose reverse prostheses is pretty impressive and can challenge you in a lot of different ways. So if you talk about one-stage revision from a hemiarthroplasty or total shoulder, which he alluded to in the last talk, the implant survivor is really pretty good. So at 2 years, you have about a 92% survival, unfortunately down to about 75% at 5 years. And they have fairly decent function, and satisfaction rate's fairly high. So using a reverse in that situation is pretty straightforward. If you're going to revise a reverse to a reverse, though, the most common cause obviously is base plate loosening, and the biggest challenge is glenoid bone loss. I think, as we mentioned before, the humeral side concepts are fairly routine. The big thing is how you classify the bone loss. These are the types of defects you can see that Frankel talked about back in 2009, and these are the ones that give you the real challenge. The B2s and Cs, most of us can deal with those, but it's these big, huge cavitary losses or rim losses that are the ones that are hard to deal with. Cofield and Sperling published this in 2001. Also just another illustration of the kind of defects you can have, but usually in these instances you're going to see the combined defects that are really quite extensive. So what are your options for the glenoid? One is bone grafted. You can either one-stage it or two-stage it. For patients who have already an implant in, obviously you're going to have to use allograft, or you can use iliac crest. The difficulty with iliac crest is that many of these defects are so large that there's really no way to put in a iliac crest graft that's going to contain the defect. So Frankel did look at using bone grafts in patients who were having primary reverses. These are not revisions. And he used humeral autograft in 91%, which obviously would not be capable in a reverse to a reverse, and also 9% got allografts. And as mentioned earlier, he said 98% had graft completion and there were no base plate failures, but his follow-up was quite short. I would venture to guess that over time those numbers changed. Cofield and Sperling, they looked at 41 patients, and they really tried hard to get at least 2 peripheral screws in the base plate to have good fixation, and they had a minimum 2-year follow-up. And they had good clinical outcomes, but they had a very believable graft resorption rate of around 23%. And admittedly, at their short-term follow-up, they didn't have any revisions, but that can obviously change over time. There was a systematic review looking at bone grafting defects, and this is really for not only reverses but totals. and they found that the graft union was 95% and revision required only 2%. I still think that's a bit optimistic, but they did suggest that when doing the bone grafting that concentric grafting did better than eccentric grafting. So my biggest issue really is bone grafting, the glenoid. I find it very difficult. I also, not only technically, but I have very hard time believing that allografts heal as well as everybody seems to say in the literature, and so I should probably go on another traveling fellowship and learn how to do it right. I think also unless you have navigation, orientation of the screws when you're trying to revise these is very dodgy, and trying to get a screw in good bone is very difficult, and so I think it's very hard to do. So here's a patient who had a failed reverse that was converted to a hemiarthroplasty. We did an iliac crest bone graft, which we sort of laid in there and put impacted cancellous bone as well. Unfortunately, it failed at 1 year, and he was perhaps a little bit worse off. So we used CT modeling and went to a custom glenoid component in his case. You have to collaborate with the engineers, but you can see it's very difficult to bone graft a big cavitary defect like this. So this is what we put in. These custom glenoid components are limited goals only. You have to do slow rehab. This guy was a little bit exuberant, but oddly enough, they get great pain relief and pretty good function. The bad news is that I saw this guy back 2 weeks ago, and his glenoid's loose. So custom glenoid components, again, here's another patient that had not a reverse, but a failed total. And you can see the extensive glenoid bone loss on the right. We put in this prosthesis, and it did quite well. There's only one published study looking at using these custom things, just published last year from a group, I think in the Netherlands. They had 10 patients with severe defects. They didn't have any revisions, and everybody had good outcomes. But again, this is very tentative, and I kind of, every time somebody comes in after having one of these placed, I kind of very slowly look at the x-rays and hope that they're not falling out. So for a failed reverse, you can do a 1-stage or you can do a 2-stage. It depends on your capabilities. It's certainly a very challenging problem. There's all sorts of things you have to consider, not only just the etiology of why it's loose, but what the patient factors are, also how big the bone is, and certainly their evolving techniques of what to do about these big, huge cavitary losses of bone in the glenoid. So there are many causes of reverse failure. Glenoid bone loss, I think, is the major issue for me revising these. I usually do a 1-stage if they're not infected, a 2-stage depending on what the implant or the problem is. And I think custom components offer a really great solution, but I don't think there's enough follow-up really to recommend them. So again, I want to thank everybody for having me here. This is a fantastic meeting, and I want to thank the brothers for having us, and also the faculty who's been, I think, really fantastic. Thank you very much.
Okay, thank you very much.